Who are some of the most challenging groups in terms of PrEP, in terms of like taking the therapy? I'm sure there's some that are more challenging than others.
I mean, I think right now we're still at a point where we're not necessarily getting PrEP to the people who need it the most, right? So we've seen, rapid increases in uptake in the last 5 years in the U.S. of pre-exposure prophylaxis, but it's generally been adopted by more educated white gay men.
Older too.
And older, exactly. And who may very well are at risk as well for HIV, and it's an important intervention for them as well. But where we see the highest rates of infection among young black gay men, we're not doing as well, and that less than 5% of young black gay men in the U.S. have actually used PrEP. And so this is a combination of factors that lead to this, and one is knowledge of PrEP. We still see plenty of young black gay men in Atlanta who've never even heard of it. They don't know anyone who's taking it. They don't know if they really trust, getting a medical intervention on a daily basis in a young, healthy person. And so all of these things become very complicated. And then beyond that, it's accessing it. So there's a lot of access points in LA. There are some in Atlanta and the Southeast, but we still have a large population that does not have access to health care because they're uninsured or underinsured. And those people are maybe not able to get the medication because it is such a medicalized intervention.
And adherence? I mean, this is one pill once a day, not a lot of side effects, but...
Well, I think that what the studies have shown is, at least in men, or men who are having sex with men, that if you are taking as few as 4 tablets a week out of 7, you're going to be pretty well protected, and about as well protected as if you're taking a pill every single day. And as Colleen mentioned, it's less clear in women that you can get away with less strict adherence. But I think the challenge is that, again, adolescents and people who are most at risk may be the ones who have the greatest challenges with adherence, and clearly the intervention works only if it's taken.
And we have data, right, in adolescents. There have been demonstration projects in adolescents where the proportion that actually take the pills is low, and then over time it decreases even further. So it really kind of getting sustained.
Yeah, and for those of us who've been sort of following the PrEP field since the beginning of the decade, we come to appreciate the role of adherence in the problem. But for those who haven't been, I mean, it's just a huge issue that came out of all the randomized controlled trials, including 2 large studies in high-risk heterosexual women that showed no efficacy.
Right.
And it was only in retrospect, despite saying they were taking medicines consistently, that the data demonstrated that they weren't even taking it a third of the time.
Yeah, so PrEP is one of those such a unique situation where, after the clinical trial, efficacy actually improves or doubles in some instances, which, is not what you're taught in your, epidemiology classes or in medical school, which should happen, right? Efficacy should dilute when it goes out to the general population, but PrEP is fascinating in that way.
Yeah, one problem, right, is this issue, with antiretrovirals for treatment, you follow the viral load. And so when someone's viral load doesn't change, they're probably not taking it, and we'll get to that. But with PrEP, the question is, how do we know if someone's taking it?
In the clinical trials, they, do patient self-report, which is notoriously poor, and probably worse for PrEP than it is even for antiretroviral therapy, because there is no backup. And then people look at things like, pill counting, which we're not going to do in clinical practice. It's very hard to do. Maybe we can call the pharmacy and make sure they're picking them up. And then blood levels. So there's a lot of interest in developing things like point of care measurements of blood levels to see if people are actually taking it. Because it's so important, right? Because people are falsely believing they're protected, falsely believing they're taking their medications consistently, and are taking a medicine that, although well-tolerated, easy to take, and we would want everybody appropriate to access it, has some risks.
Sure.
And costs.
And I think, that's a, go ahead, Daniel.
I was going to say, one bright spot is that we haven't really seen the emergence of a lot of drug resistance as a consequence of PrEP. That's been a big worry because people might be intermittently adherent to PrEP, and if they had stopped taking their PrEP and got infected and then started up again, would they be under-treating HIV infection? And at least to date, that doesn't seem to have been a big problem. Certainly in the clinical trials, although there have been a few cases of resistance reported in practice, that has not been a major issue, which is reassuring.
But the issues of resistance that have come up in this goes back to the beginning of our conversation, is people that get started on PrEP during that acute infection period.
Right.
And I've done it myself, where I have started someone on PrEP in acute infection and they've developed HIV drug resistance. And so it is something to be very mindful of and to screen as much as you possibly can for acute infection when you're starting someone on
you
PrEP.
probably have a pretty low threshold, I get, for screening for acute infection.
That's right.
And what that means, I think, operationally, is not only getting a 4th generation test, the one that Eric mentioned, that antibody and antigen, but also probably getting a viral load. If you really think someone has acute infection, they have some sort of febrile illness, so really getting that done.
The other big issue with PrEP is this whole concept of risk compensation that we worry about. And you know, I have sort of mixed feelings when we talk about it, because on the one hand, I think we need to pay attention to it.
Absolutely.
I do think people who are on PrEP may be using condoms less and putting themselves at increased risk for other STDs. But I by no means would any of us want to suggest that because they're doing that, we shouldn't offer PrEP. It's the right intervention. It just means that we need to be monitoring them closely for things like STDs and try to intervene as early as possible. And the guidelines are pretty clear that we're supposed to be doing
as an
that.
infectious disease community, we need to shift our attention all to sexually transmitted infections and thinking about new innovative ways to prevent and treat sexually transmitted infections as well that have kind of been ignored.
Yeah, I think that's a big part of the responsibility of being a PrEP provider, is that you're going to follow those guidelines, you're going to screen for STIs, and you're going to know how to treat them.
That's right.
But I think, Eric, what you said, I've heard it from others. I mean, obviously nobody here on this panel, but say, well, if they're not going to try to use condoms, I'm not going to prescribe PrEP. And that's exactly the wrong approach.